He's the president-elect of the STDD, the Association of State and Territorial Dental Directors. He currently chairs the Fluoride Committee. Dr. Roush is also a clinical assistant professor in the Department of Dental Practice and Rural Health for WVU School of Dentistry. Also presenting is Julie Jackson. She is the program manager for the West Virginia Oral Health Program. She is a registered dental hygienist and holds the National Certificate in Tobacco Treatment Prevention. And lastly is Ravi Parker, who is the prevention coordinator for the West Virginia Oral Health Program. Ravi graduated with a bachelor's degree from WVU in dental hygiene in 2011. He has worked in private practice and pediatric dentistry for 7 years in the Charleston area and was also a professional educator for the Waterpik for 2 years. He joined the Oral Health Coordinator in February of 2019. And now I will turn it over to your presenters.
Thanks, Luke. Are the slides up?
They're taking their time. Sorry.
Okay.
It's
No,
coming.
you're fine. How about I'll go ahead and start and you
Catch up.
catch up.
Okay, that sounds good.
Yeah. Again, thanks, Luke. And, of course, from the oral health program, we like to enjoy the opportunity and appreciate the opportunity to talk about our program. And today, really, that's the goal. I want to cover as much, the three of us want to cover as much material, share as much material about the program, just to give you an overall, some overall background, some knowledge of what the problems are, what we're trying to accomplish. But back in we start back in 2009. Can you all hear me fine or feedback?
Okay. Please remember to mute your lines. Try that. Dr. Roush, did I mute you too?
How about now? Do you hear me?
Yes.
I'm just talking away.
Sorry.
No, I'll start back here in 2009. I'll start back at 2000, and basically, oral health became a priority in West Virginia. Basically, centered around a Pew report. That West Virginia unfortunately got the grade F. So I guess it was good. I mean, bad we got the F, but it was good that it gave some attention and kind of gave some oral health a priority here in West Virginia. And that Pew report basically had some policies, some certain policies that needed to be in place, and some specific infrastructure. So in 2010, I became the first full-time director, the state dental director in 2010. The oral health program is in NDPH. It's in the Office of Maternal, Child, and Family Health. Basically, that office has, most of the programs related to kids. Around the country, oral health sets in kind of different places. You've seen one state. But typically, they'll either set in your MCH programs or it'll be in chronic disease programs. The Center of Disease Control is actually in the chronic disease. But there's some Yeah, the one thing when I first started, you look at other states and you look at the Pew Report and you look to see what you got to put in place, basically to be competitive to get these, to get federal funding. And basically you have to have, you start with some infrastructure in place. You have to have a state plan. You have to have a surveillance system, and you have to have a coalition. And that's basically, that's where we spent the majority of our time, just trying to get certain pieces in place. We got our first grant from the DentaQuest Foundation, and basically use that funding to try to set the stage for that next CED grant. I'm not going to talk about all the grants specifically, but I will tell you that we've been, we've done a great job when it comes to basically time for federal funding, and we received about every grant out there. Prior to 2016, we've got every grant available. Now, the last couple of years, we've missed a couple, but we've done a fairly good job of securing funding for our state. I'm going to skip on where it talks about the most prevalent issues. As far as the kids, slide, no, you're right. So when we do surveillance, our surveillance plan is basically, we try to do a certain age population every year. And basically, we have our Head Start or our universal pre-K population is one. We have our third grade. We have older adults. And then we have an adult population. And we're the only state to do one on the perinatal population. But one of the main issues that we have with the kids is basically the kids are entering school with a caries experience. So about 50%, a little over 50% of our kids have had a caries experience. So caries experience means that they've had caries. So it could be untreated or treated. Of the ones that's been that have had caries, 21% of them have not been treated. So I think we're doing a fairly good job of getting the treatment. We're doing a real good job here in the state of making sure kids have access to the preventive services prior to school age. And that's something that's a challenge. There's a lot of challenges, but one of the challenges is our workforce in the state is an older workforce. Even I think I'm young, but I was trained on an old standard of care that we've seen kids at age 3. Now we try to get them in at age 1. So basically, we got to do a better job of getting kids in for preventive services. And throughout this next hour, we'll talk about some of the things that we're trying to do. The workforce, WVU is our only dental school in the state. They do a good job as far as graduating great clinical providers. We're doing a better job of retaining our graduates. I will tell you that when we first started, at a class size of 50, we only keep approximately 6. So things have improved there. And probably the biggest issue we have right now is the adults. I think we've done a good job with the kids. We're moving in the right direction. But when it comes to adults, there's just not a lot of places for adults to go. Primarily because of Medicaid, it only provides an emergency benefit for the adults, So unfortunately, they end up in the ER, or they end up in dental school, where they put a big burden on our free clinics and our FUHCs. So basically, most of the not dispersed across the private and the public sector. Majority of the adults are going to the public sector programs. CA, basically didn't address the adults. So actually, we don't even have to provide, as a state, provide emergency services. But this is something that states have actually expanded, and that's something that we're trying to do here. One, just because, with our chronic disease, it's hard, and if you got an infection, I don't care if it's in the mouth or where it's at. If you're going to manage a disease, you got to manage the entire body. I'm going to let Julie talk a little bit about the perinatal children.
Okay. When I came in over 3 years ago, one of the big grants was the HRSA grant. It was the Perinatal and Infant Oral Health Quality Improvement, also known as the POCI grant. You can go on to the next slide, please, Leslie. We were one of the 3 states were initially awarded. And some of our initiatives were, how can we address the age visits? How can we establish dental homes in earlier ages? And of course, we were also seeing a lot of low weight or pre with women. So with the POCI grant, it kind of covered all of them. We did the first ever perinatal basic screening survey back in 2014, which kind of showed us what some of the issues were. So what we did with this grant, we worked with our 4 NCOs on the next slide, because as Dr. Roush mentioned that, there was emergency only benefit for Medicaid eligible adults. So we did work with our NCOs to, figure out how we could at least, cover the pregnant women through routed incentives. And, one of the value adds was pregnant women could go get their teeth cleaned. Well, of course, they didn't really see it as a value because some of the other places were providing pack and play, things like that. So we decided that, one of our things was going to be we were going to offer gift cards, try to do a $25 incentive. So we contracted with the NCOs to add value add. And we did the uptake, actually, the quarter of the, we had 30 women to go get their teeth cleaned, which honestly is really big, seeing how in the previous years we maybe would have 1 per quarter or 0. So adding the incentive really helps us try to get these women in.
So one point that I want to make. So we need to, I want everyone to understand that you're not born with the gene, or you're not born with the bacteria that causes a cavity. It's transmitted. Mm-hmm. Typically, it can be transmitted from the mother, any type of caregiver. So that's why we're putting a lot of focus back on the perinatal population, back to the mom, the dad, and those programs.
And it also sets the stage for age visits, good oral health care, from birth, that, we don't wait until the child is getting ready to start school, or we don't wait until they have all their teeth to start brushing. That if we start with the pregnant women to kind of educate and, get these women to understand that it is important, we're hoping that it will set the stage for good oral health care early on. Leslie, you can go ahead and move to. Okay, and then this is where we talked about the incentive. So if you'll go on to the next. Also, one of the big things with our POCI project is we did want to work on the medical dental collaboration and the bidirectional referral. patients come into a dental office, we had no problem taking a blood pressure and referring them to their primary care doctor because they had high blood pressure or they had issues. So one of the big initiatives was, working with our medical providers. An example of this was the OB providers, to get them to send their patients to the dental office to discuss oral health care and how it does affect overall care. So we've really seen a good increase in the collaboration and the bidirectional referral with this. I'm just going to talk about the early childhood caries, and Ravi is going to take over for the next few slides.
All right. In the next few slides, I'm briefly just review the next stages of early childhood with the signs and symptoms of those. I do want to reiterate is a 100% preventable disease. As you'll see there, mild, the first stages with the white spot lesions, to progressive moderate with brown spot lesions in the first cavities, all the way to full severe ECC or rampant generalized decay. Next slide. So early childhood caries is an infectious chronic disease that disorders the teeth. It affects 35% of 3-year-olds from low-income families. It's usually caused by poor eating habits and lack of good oral hygiene habits. Some of those habits include constant snacking or bottle or sippy cup with sugary drinks, whether that be or is taken to bed at night. It does affect teeth that emerge early that are least protected by saliva. So again, starting with the top front teeth and the molars in the back. Next slide. These are not to be confused with enamel defects. These defects, 20 to 40% of children have these defects in the enamel, the appearance or the texture. Weak or chalky enamel spots can affect the thickness of the enamel. This is not caused by eating habits or poor oral hygiene habits. This is developmental. Some of the factors that can cause these include mother's health during pregnancy, if the baby is born premature, medications given to the mother during pregnancy, if the child has early and often fevers or pneumonia, constant ear infections when younger, or just poor childhood nutrition. These can be treated with fluoride treatments, restorations, or extractions if soon enough, but it was not caused by lack of effort. These are developmental. The next slide, we'll start with mild, or the first signs of early childhood caries. These are our white spot lesions, or decalcified in the enamel, usually at the gingival margin, which is right around the gum line. And like I said, this thin, chalky white line on the tooth. And that's caused by the food sitting at the gum line on the surface of the tooth too long. So patients eating food and not brushing their teeth properly. As that food sits at the gum line, the plaque, the bacteria in the plaque, metabolize and eat the same sugars that we ingest. And as they break it down, the sugar, acid starts to wear away, decalcify the enamel. If not managed, those spots can progress to full-fledged cavities. At first sign of those, change with proper eating and brushing. They won't go away, but they won't get any worse. And where they are baby teeth, as long as they're maintained, we can allow those teeth to fall out as they can. Unfortunately, if habits aren't changed, next slide. As those spots begin to progress, cavity or the hole begins to completely go through the enamel and expose some of the dentin, the next layer underneath the enamel. And these lesions can become dark as they're stained from food. Dentin is softer and more cavity prone than enamel. So once you start to see these lesions, if they're not treated and nipped in the bud right away, the bacteria is very present in the saliva and they will rampantly start to spread throughout the mouth. So once you start to see some of these cavities, it's very important to have them treated by a dentist. Next slide, if they are not treated, early childhood caries, multiple cavities in the back of the mouth. These are often severe enough, accompanied by abscess or draining of the gum, sort of looks like a pimple right on the gum. Unfortunately, a lot of children won't be able to verbalize this. They may complain of pain, but not constant. They may have trouble sleeping at night, and they'll often say they have a bad taste, or their caregiver will notice a foul odor presenting from the mouth. Patients with these teeth will often need treatment under general anesthesia, and unfortunately, a lot of times, due to those poor habits,
Sorry,
a lot of parents won't notice that the teeth have gotten to this state. They'll bring their child in saying that they fell and a tooth has broken off, and that is true that the tooth did break, but it's usually not just because of the trauma, but because a majority of the tooth structure has. So how can we prevent these early childhood caries? As healthcare providers, again, we need to educate the parents to visit the dentist regularly. Babies by first tooth, or definitely by their first birthday, need to be seen twice for exam and their fluoride treatments. We need to review good oral hygiene habits. The parents must brush for the child. A lot of parents will say, little Johnny loves his toothbrush. He'll carry it around. He'll brush 4 or 5 times a day if we let him. That does not suffice. The parents need to brush. The children are not going to have the understanding or the dexterity at their age to have proper oral hygiene. So the parents have to brush, and we also want them to brush with fluoride toothpaste. I know when I first started dental hygiene, I believe the guideline was 2 years old. So now it is that of the first tooth. So there really is no need for training toothpaste at this time. We smear toothpaste just enough to make a slight foam to brush their teeth. Stressing flossing once their molars are coming in and there is contact between the teeth, as well as their eating habits, of course. As Dr. Roush touched earlier, not to clean a baby's fire with their mouth or share brushes, cups, and utensils. That bacteria, if the caregiver, or the primary caregiver, or mother or father has decay and they're sharing and swapping saliva, that's transmitting those prevalent bad bacteria back into the baby's mouth. So you want to make sure not to do that. Avoid any bottles or sippy cups or at bedtime. Again, it's not as much that the drink is bad for the teeth. In my old practice days, we used to recommend a juice. They have it at a meal or in one, but it's the frequency. You want to think about if you're bathing the teeth with apple juice throughout the day with a cup, or drinking it before you go to bed at night. Sit on the teeth. That's what's going to help feed the bad bacteria. How can we manage the early childhood caries? Dietary and oral hygiene counseling, fluoride varnish applications, which we'll get into in just a little bit. And of course, referral to that dental home for their comprehensive. Again, the white spots, when you first see those, get them to a dentist, they can get that counseling. Once they have cavities, those need to be treated right away. And if you see the rampant decay, they are in severe need to try to avoid those infections and other issues. I mentioned the fluoride varnish, and there is a training program designed to educate primary care providers and their staff to perform a caries risk assessment, apply the fluoride varnish, and then facilitate that age 1 dental visit. Our target population is children ages 6 months to 3 years old who are at high risk for developing dental cavities. The fluoride varnish training program was initiated by West Virginia CHIP. Reduce rates of early childhood at risk in West Virginia, and administered now by the World Health Program. That was the next slide, and we'll go on to the next one after that.
Yep.
What is fluoride varnish? It's a highly concentrated form of fluoride which is applied to the tooth structure. You simply paint it on. It can be applied by the dentist, the dental hygienist, or another healthcare professional, and it's a type of fluoride therapy. It's easy to apply and sets quickly. It comes in many flavors, so it's more appealing, especially to children. It's available in many colors, but most providers will use a tooth-colored varnish just because it's more aesthetic and agreeable to the patient. So why is fluoride varnish important? For dental caries is bleeding, chronic infectious disease for children in the United States. I also mentioned that earlier. It's 5 times more common than asthma, 4 times more common and 20 times more common than diabetes. In West Virginia, 34% of preschoolers have already had a cavity, And studies have shown that 25 to 45% reduction of cavities if the patient is using their fluoride treatment. It's very important, very cost-effective way to avoid those early childhood caries. The target populations with fluoride varnish, again, children from birth through 6, especially those at high risk. This level is determined by the completion risk assessment. To apply these, oral steps, provide an oral health screening with caries assessment. You can apply the fluoride varnish and then that anticipatory guidance to the family. It can be done 4 times a year, twice by a dental provider, and twice by a medical provider. When performing an oral health screening and caries assessment, you simply lift the lip and look in the mouth for any signs of decay. First, look for that smile, those white spot lesions at the gum line. Next, look for any brown spots or cavities. And if they do see, if you get decay, look around the gum line for any of those little pimples, those fistula, for any abscesses. Some key factors to determine if the child does have, is at high risk for cavities. Do you see any white spots or current decay? Has the child ever had a cavity or filling in the past? Have any of the child's siblings had a cavity or filling in the past? And has the mother or the caregiver had a cavity or filling in the past? If any of those, yes, the answers to those questions, yes, that child is at high risk and would benefit from fluoride varnish treatment. And then obviously you want to refer that child to a dentist as soon as possible. States, both West Virginia Medicaid and West Virginia CHIP have expanded their reimbursement for those fluoride varnish treatments. For West Virginia Medicaid, it's from ages of birth to 20 years old, and for West Virginia, 6 months to 8 years. Again, there is now a code for primary care providers, as well as your dental providers. So eligible children can receive up to 4 applications of fluoride varnish a year, 2 from a dental provider, separated by 6 months, and another 2 from their non-dental or medical provider, as long as those are separated by 6 months. Both of these 2 applications by medical provider is recommended to take place in conjunction with their annual well child visit, which is one of their mandated visits, and training via Smiles for Life curriculum, specifically course 6 on the website. It's recommended, but it's not required for reimbursement. So it's sort of everyone on the same page, which gives you a common understanding, but it is not required by either program. 2 slides, simple Medicaid and West Virginia CHIP codes. The 99188 code is for the medical providers. Again, that can be used twice per year, as long as they're separated by 6 months. And then the 1206 or 1208 code for the dental providers. The next slide is the same thing. Virginia. Again, to participate, you can complete the Smiles for Life curriculum, course 6. It's free at that website link. It is optional. You can conduct your caries assessment, provide that fluoride. That takes a minute. Most patients like it. Unlike the fluoride treatments that many of us grew up with, sit with the tray and wait 4 or 5 minutes. This is a simple 1-minute procedure that you paint on the teeth. The varnish kind of sticks to the teeth, almost like glue. The patient, once they leave your office, is able to do right away, and we just don't have them brush that night. It's a pretty simple procedure, and they can go right about back to whatever they're doing. You can refer those children an age 1 dental visit. First 2 for first birthday, easy way to remember for the first dental visit.
So just make a point, that the fluoride varnish program, probably for this group, important note to remember is basically the project is a program designed for the medical providers and their ancillaries to provide a preventative service, an oral health preventative service. If you remember, go back at our school age, 50% of those kids have had active decay, so we're trying to engage the medical community to provide preventive services to try to bring those numbers down. So on this slide, the Center of Disease Control, and this is Community Preventive Services Guide to Community Health, but CDC recognizes two evidence-based strategies for oral health. One's community water fluoridation, and the others is sealants. Delivered sealant programs. In West Virginia, I'll tell you that about 90%, close to 90% of our public water systems fluoridated, which is great. The problem is a lot of our kids don't live in those public systems, so that they still have still do wells. And we do provide, we'll test those wells for them and provide supplements if needed. The two strategies is the fluoridation, sealants. I'll take this slide. So a lot of our interventions when it comes to school age, of course, everyone's intervention seems to be is related to school. The out is, and that's where we have access to the kids. So we, our dental sealant programs, basically, we utilize the school system as our access points to the schools to deliver those sealants. It's estimated there's 51 million school hours missed every year just for dental condition. So oral health, that doesn't only affect overall health, but also affects our school performance. Do you want to talk about BSDH?
Do you want me to?
Yeah, I'll let you talk a little bit about it.
Okay. So here's our EPSDP. So in review of the West Virginia Center for Medicare and Medicaid Services, that's our CMS 416, which this is the information shown right here. Annual early and periodic screening, diagnostic, and treatment participation reports from the last available 6 fiscal years. So this is showing you 2012 to 2015. The utilization for preventive dental care from 0 to 20 years is 43.8%. The table shows the breakdown of utilization for preventive care by age group, as well as the overall annual average. So addressing the needs of children and youth with special health in West Virginia, especially in our youngest population, new and evolving dynamics, the light of the opioid epidemic, support for the MCH population community. So you can see we've kind of had a little bit of a rise and a little bit of a fall, but I mean, they're staying about the same per age group. You can see there's a little bit of a take in the 3 to 5 year olds because, we do have the dental visits up on school entry. And then, it kind of plays up a little bit with our 6 to 9 year olds. When you start getting to the 19, 20 year olds, it does start falling back away. So we are trying to work on those populations to try to keep kids seen for preventive care. The next slide. We're talking about substance abuse trends. This does to our children and youth with special health care needs. So the number of West Virginia children entering foster care, particularly those aged 0 to 35 months old, those identified with neonatal abstinence syndrome, and those being referred to has increased proportionately as the number of opioid deaths have increased. Children in foster care are now categorically eligible for care coordination services for the state Children with Special Health Care Needs program, as they are considered state, and you'll hear us say HPN or CYFHPN. So the National Survey of Children with Special Health Care Needs, last completed in 2010, there were an estimated a little over 70,000 children and youth with special health care needs in West Virginia, and the prevalence of SHPN continues to be one of the highest in the country. So More recent data in 2016 estimates the number of children and youth with special health nearly 1 in 4 in West Virginia children, which exceeds the national rate of 19.4%. Okay, so next slide, we're going to talk about the Oral Disease Prevention Project. Do one of you want to talk about this?
So the CDC, our Oral Disease Prevention Project, our goal is to increase the number of public school students with sealants, and with collaboration with the West Virginia Board of Education, Policy 2423. We'll go to the next slide. Over the beginning of the last 5 years, this will be the 6th year, going into the 7th. Us, along with the state, along with the West Virginia Board of Education, has put a policy in place for new enters in West Virginia public schools, pre-K, kindergarten, 2nd, 7th, and 12th grades to show proof of an oral health exam at the beginning of the school year. So we now have all of those age groups who need to have an oral exam before they start within 45 days of their of the school year. The next slide goes over the phase-in plan that occurred over those last few years, beginning way back in 2014, and first starting with pre-kindergarten, so for school entry, then to include 2nd grade, ultimately 7th and 12th grade last school year. Yeah, that's just for the same policy. And then some of our oral health survey on 37 schools, 3rd grade. 1,190 students received a dental screening, 48% response rate. With implicit stratification by health region, 4 regions of systematic probability, proportional. The size sample was used to select a sample of 37 schools. If a school refused to participate, their placement was randomly selected from the same sampling interval. And we have some of our results over that. Our baseline for the reduce the proportion of children from age 6 to 9 who have dental caries experience in their baby or permanent teeth. The baseline was 54%, and our results showed that it was 48% had experience. That refers to having untreated decay or previous filling, crown, or other type of restorative dental material. I also wanted to reduce the proportion of children 6 to 9 with untreated dental decay, and the baseline was 28.8%, and our results showed that there was 8.7% untreated decay. That was dental cavities or tooth that have not received treatment. Next, we wanted to increase the proportion of children aged 6 to 9 that received dental sealants on 1 or more of their permanent first molar teeth. The baseline was 25.5% of those children from 1999 to 2004, and our results showed that 28.3% had dental sealants in those first molars. For those of you who don't know, dental sealants are plastic coating applied to the chewing surfaces of the back teeth or the molars. They apply sealant resin bonds into grooves of teeth to protect a barrier and to protect those permanent molars from cavities. Some more results: 18.5% of those surveyed needed dental care, and 2% need urgent dental care. Urgent being a child had pain or an infection or abscess at the time of their screening. I'm going to turn it back over to Julie to go over some of the workforce.
Okay, so we talked about some of the issues that we have. A lot of times we hear, well, we don't know where to go, we don't know. You can get on the insurekidsnow.gov. They can direction of who accepts Medicaid, CHIP, like that. If you want to skip on to the next slide. In West, we have 1,392 dentists in West Virginia. This is by county to show you where we do have dentists, of course, in every county. The next slide, dental hygienists by county, we have 1,576 as of this year. The next slide talks about our workforce. As Dr. Roush had mentioned earlier, you know, of course, you guys know we only have one dental school in the state. We do have schools. So our graduating class, we did have 47 graduates this year. 16% or 16 associates in practices throughout West Virginia. We did have 21 residencies going, which 18 plans to West Virginia. Associates out of state, and as you can see, one military, out of the country, decided. So if we retain 50%, or if we come back, we will have 58% coming back. So that is a big improvement. Our next slide, one of the issues, you know, we only have 17 board certified pediatric dentists in our state, 15 currently practicing. So the good news is WVU is in the process of opening their pediatric residency program. So, you know, yeah, they are working on that. So we're hoping that here in the next, once everything is up and running, that we will see more pediatric dentists in the state. Dr. Roush had mentioned in the beginning, you can go to the next slide. Grants that we had, we did have a HRSA dental workforce and did provide a lot of dental equipment into a lot of our areas, the dental shortage where, you know, dentists would like to be able to see people, but we don't have proper equipment or we don't have the staffing. So with our HRSA grant, we were able to provide a lot of these offices, these FQHCs with services so they could provide additional care. Next few slides just show that it was a project. We were awarded approximately $25 million. It did help with the retention efforts to keep some of the dentists in the state, and we did end up giving a total of 20 grants next period. We partnered with the Center for Rural Health and Development, the low interest loans to kind of keep this stuff going to stay afloat. Go on to the next slide, Leslie. And okay, we've already gone over that. I feel like we've I'm talking way ahead of the slides here. Next slide. Some of the other big that we have promoted is our state loan repayment program, and this is for dental providers, also for primary care physicians, nurse practitioners, nurse physician assistants. They are obligated to provide services in dental shortage, which honestly most of West Virginia is considered an area. The state loan repayment will pay expenses, training expenses, and living expenses, just to keep these providers in these areas. The next slide, this just talks about some of the criteria providers that they must meet in order to accept services. The next one is the recruitment and retention project. It goes along the lines of state loan repayment. You can read the criteria there, but it is up to $12,000 a year for a total of $80,000 if the providers are working in these dental or these providers for these areas for the number of years. The next slide, Dr. Roush can talk a little bit about, the adults and some of the seniors, and if you want to go over some of that.
Well, I think, the main thing to know is with adults is that it's hard to address children's issues. I'm not going to go into the details, the numbers, but it's hard to change the behavior of the child if the caregiver, the mother and father, the grandparent, have bad oral health conditions. If they have bad habits, they don't have value or don't understand the value of oral health, it's really hard to to have an impact on the child's health. So, in West Virginia, by not addressing the adults, I mean, it's really challenging to have a drastic improvement or impact on the child at such a young age. And I think we've been successful with some of our projects, but it's been those projects, particularly when with the access to school. And particularly, I hate to say it, but sometimes that's because the parents are not involved. So we're working with some of the care coordination programs, our birth three, right to start. A lot of focus is being put on that younger age. I mean, from that perinatal population up to Head Start. But I'm not going to talk a lot about adults. I will tell you, with adults, put the burden on the ERs and our public systems in general, our public programs, and really, WVU, the dental schools, that's where a lot of those cases go, especially the challenging cases. But I'm going to wrap things up and then give some time for questions. I think particularly when we're talking about children with special health care needs, the data that we get, some of the data that we went over, that would include, that subset of population that they're included in that population. So what's important to remember, our foster care kids now are part of that population, but children with special health care needs, I think it's that much more important for them to have access to the preventive services. If they have a decay, the child has decay, a lot of times, depending on the situation, sometimes it's tough to treat some of these children in the private setting. Sometimes the providers don't feel comfortable treating those children. We really don't, like I said, we only have 16, 17 pediatric providers. A lot of times these cases end up in the ER, not ER, but the OR, and that's an expensive case. You're talking, could be up to $20,000. And it's, so I think the important point, if you don't remember anything else today, is really the prevention. The industry right now, the focus is, most of the work is is restorative care, but we need to put more focus on prevention, especially for this specific age group or this population, children special health care needs, with the goal that they don't need restorative care. And then there at the end, we talked about, data. We talked about surveillance, data evaluation. Data drives policy. It drives change. And I talked about the Pew report that we had, the F, that same report today with BNA. But just because you have policies in place, you have the infrastructure in place, and you have everything in place, when you talk about public health, it takes time. And it might take 10, 15, 20 years before we see some of the impacts of some of the work and the things that we've been put in place. So we just got to stay the course. We need to strengthen the relationship between that medical community and dental community, because those providers, the medical community, see those kids at a much earlier age, and that's something you're going to, more about the years to come. Something that we need to get better at. But how it is, we treat the same kids, but there's still a disconnect. It's something that those communications, relationships have to improve, just not for the kids, but for the adults. But I'll turn it back over to you because I could talk all day. And I know some of you get hungry, but if you have any questions, we'll try to answer. I know we covered a lot.
No, this is a great introductory piece for sure, and perhaps we can get you back for other things because you are doing a lot. I'll save some questions I have, but let's open it up. Does anyone have any questions for Dr. Roush and his team?
If you don't have questions, I'm going to talk for another 5 minutes, maybe 5 minutes. Just teasing. But we are working on a state plan. It'll be not this state plan, but a state plan. So West Virginia Coalition is going to take the lead on that, and it will be a state plan. So, if you are interested in cutting in on some of those meetings and have some specific activities in that plan, you're welcome to.
Great. I think people have unmuted some of their lines. Anyone have any questions?
I don't have any question, but I really enjoyed the presentation, and I thank you for the work that's being done, because obviously dental care is a huge issue in our state. And I know even with our clients, Funds for You, we use a lot of that for dental care. So just thank you for what you're doing.
Thank you.
I don't have a question.
Oh, I'm sorry.
I don't have a question either, but I do want to thank you for this because I do have a special needs son, and dental care has a major issue because he has to be put to sleep and he had issues with anesthesia. So therefore he had a hospital setting to have dental care. So that has been an issue his entire life, getting good dental care. So this is great that you are doing these things for our population.
Well, we appreciate you sharing that. Unfortunately, our goal is, that's what we want to prevent, right? So you sharing those stories, helps us, kind of move forward, with
Is Dr. Roush, knowing that many of our groups, many of the individuals on here, if not all, who are listening, interact with families in many different ways, and families of all ages, it kind of gets at that generational piece that you spoke of. What would you advise them to do? Some are seeing them in home visits, some are seeing them in the clinics, medical clinics, some are seeing them in their schools or other settings. If they see this and they're not doing the assessments per se, what should they do? What would be the first things?
Well, the first thing is, as a family, don't rely on, I don't want you to necessarily rely on the public sector to meet those needs. I would assume for you to take the initiative and take your child to your medical provider for their EPSDT, and if they ain't doing the oral health piece, call them out, because they all should be informed of it. I will tell you, a lot of them don't do it. So that's one thing. The second thing is you need to go ahead and is go ahead and start that, start taking your child to your dentist, by age 1. And that appointment is, a lot of it is educational.
Mm-hmm.
And if you call officer that doesn't want to see them, call us and we'll find you one that will.
Okay.
So I mean, reality is, we're all in this to get together. But the one thing I've learned, it's hard to change the way someone practices. As far as the dental side, that's what I'm saying. A lot of us are, trained on old standards of care, so it's hard to change that. And then it's the same way in the medical community. So it's hard to change the way we practice. The time to do it, I think, is doing a better job while they're in school, trying to put things in place for training together. And that's some of the focus. But, don't be afraid to speak out, because, you know now that we want you to go out in there at age 1. Don't be afraid to tell your neighbor, because reality is, you have as much influence as what we do, probably more.
Are there, related to that, are there any materials on your website or elsewhere that you would recommend we share? I know we put some things about the dental clinic in the clinic folders, but we have a lot of other programs that are outside of our clinic. So are there things that we should put in our intake packets related for parents and families?
That's something that we can talk about.
I was going to say, I can send you several things that we have, here that we do give out at health fairs or different health events. I can send you stuff that you can, just to talk about age 1 dental visits and the importance of, and how not to share things, from the parent, the caregiver to the child. I can send you several things.
That would be
so
great.
Our goal here is to incorporate oral health into every MCH program in the state.
Okay.
So oral health will be in FERPA 3. Oral health is going to be in Right to Start. Oral health is going to be part of EPSD. Oral health is going to be part of Children's Special Health. It's going to be part of every MCH program. Actually, if you really want to actually fix oral health, it can't just be oral health program. Oral health has to be integrated across every program in the bureau.
Okay.
So it'll have to, eventually it's going to have to be involved in all the chronic disease programs. It's going to have to be, for now our focus has been more on the NCTTP programs, because those are the ones we have an influence on. I think change happens through, it's just going to happen through repetition. The more people hear, through all our educational programs from the medical community, dental community, our care coordinations, those trees right from start. Start to see a change, but hopefully the family, has a role too. That they can, hold people accountable.
We have provided oral health information, all of those programs, to give, into their home visitation programs and into the medical communities and stuff. So, yeah, Leslie, I can send all that stuff to you, and you can decide what you want to.
That'd be great. If we have your approval on that content, then just giving everyone some options about from there what they have time for, who they'll be talking to, they can pick and choose. That'd be fabulous.
Okay.
Thank you, Julie.
Yeah, I'll get that together and send it to you.
I think what happens with our specialists is that they get overwhelmed by probably treating kids that would not necessarily wouldn't have to be treated in that setting. Some of the private dentists just don't feel comfortable working on young kids. So then it even makes it that much more challenging when you have a child with with special needs. Because now we have a child that could have been seen in the private sector.
Right.
Taking up time in one of these 15 or 16 offices. And time, that last time creates more problems because, it's a disease process. It's not treated. It's going to get worse.
Mm-hmm.
It's a continuum.
Okay. Yeah.
Yeah, oral health's got a lot of challenges. We're doing good. We're not where we need to be,
Yeah, no, it looks like you're making great strides. So we're over 3. Does anyone have any other pressing questions? I don't want to cut it short.
She had mentioned a website earlier, but I didn't catch what the website address was. I think it was Julie.
Leslie had mentioned that it was on the very last slide with Roush's information.
and I skipped it.
But it is www.dhr.wv.gov/oral health.
Thank you.
On the very last.
And that is the very last slide, yes. That has some of the information that I can also information to Leslie, and then if she wants to pass it along.
Okay.
Right there at the bottom. I need to update the website and add a little bit more.
That'll be great. What's that?
And we have done work specific to children with special health care needs. Like the clinics, we have thought about putting a dental hygienist or a dental provider at the clinic to assessment. But the big thing is we are helping support the new pediatric provider there at Ravi with the hopes of establishing a residency program.
Yeah, that'll be good. You have several of our positive behavior services, support services program on here watching this. And I know that in the past we've had an OT faculty member who's specifically trying to design programs to make dental visits a little easier for children on the autism spectrum.
Mm-hmm.
And so together, I think that would be a spot that that skilled on the behavioral side, and then with some interest in other programs, maybe if that ever comes up and we have the opportunity to expand that.
I will tell you that I'll just tell you now, we're going to need some help as far as that residency program. One of the requirements is a clinic. They'll have to be there at the hospital. So, if you go to Pitt or another university, that they have, that they might have a big clinic with numerous chairs. I'm not saying we need something huge, but that's something we're going to need.
Okay.
So we can treat those there at the hospital. There'll be a clinic in the hospital.
Okay. That'd be great.
We've already had those discussions.
Great. So definitely more to come. And we're over, and I appreciate your all's time and patience as we got this started. And this was really, really interesting. So thank you. And thanks everyone for joining us.
Thank you. We'll be more than happy to talk anything, and we can dig into one specific area. We just thought we as much as we could actually today, but we do appreciate the opportunity.
Oh, more to come for sure.
All right. Thank you.
Thank you. Appreciate it.